Hello, everyone, and thank you so much for joining us today at the Spring Science Symposium. My name is Toshi, and I'll be presenting my recent research on hepatocellular carcinoma, or HCC, focusing on analyzing its mathematical dynamics under an immunotherapy that is currently in clinical trials. So let's start with the basics. Hepatocellular carcinoma is the most common type of primary liver cancer. This is a crucial topic as HCC accounts for over 900,000 new cases and 800,000 deaths each year worldwide. The significance of my research stems from the poor prognosis and unpredictable nature of this cancer, highlighting the urgent need for effective treatments and learning how it behaves. Despite being less common than lung cancer, as you can see here on the graph, comparing liver cancer and lung cancer, liver cancer still has a lower 5-year survival rate, making it a more fatal disease that demands more attention. This is why there's a need to address the relatively less prevalent types of cancers out there, such as liver cancer. Even though there is no absolute cure for the disease, there are a few treatment modalities that are able to suppress the tumor growth and prolong patient survival. And why do we choose immunotherapy over other types of treatment modalities? Immunotherapy targets specific mechanisms within cancer cells or the tumor microenvironment that are not typically addressed by traditional therapies, such as chemotherapy. For example, immunotherapies that target the PD-1, PD-L1 axis can rejuvenate exhausted T cells within the tumor microenvironment, helping to induce remissions in cancers. In addition, immunotherapy has been noted for its effectiveness even where traditional therapies fail due to drug resistance, as the adaptation of involved antibodies shows the dynamic capability of the treatment to overcome resistance by modifying the immune landscape around the tumor. Since the data I received involved in immunotherapy clinical trial, here's some essential information on immunotherapy. Immune checkpoint blockers, or ICB, the drug, act by reverting the immunosuppressive phenotypes of cancer cells, thus allowing the host immune system to generate an immune response to the tumor. And one of the key mechanisms targeted by the ICB is the PD-1, PD-L1 axis, which lies on the interaction between the programmed cell death protein 1 and its ligand, overexpressed in several tumor types. And this interaction leads to the inhibition of T cell proliferation and their apoptosis and exhaustion. So anti-PD-1, PD-L1 monoclonal antibodies are now the mainstay of treatment for several advanced stage tumors. Just like the one I was analyzing as TSR042 and TSR022 are novel IgG4 anti-PD-1 antibodies that have yielded remarkable results. After all the biology behind my research, let's talk about the math aspects of my project. So the main math involved is mathematical modeling, as you can see here. It's an approach that uses mathematical expressions to represent and analyze real-world systems and phenomena. Essentially, it involves creating mathematical equations or relations to predict and understand complex behaviors and practical applications across various fields, including oncology, which is the study of cancer. And I'll be using mathematical modeling to model the growth of the tumor size under a certain treatment or immunotherapy in this case, and finding the parameters to estimate the progression. And the three models I used to model the dynamics are linear, logistic decay, and bi-exponential decay models. The linear model is used to set a baseline for model comparisons later on. And according to many studies, logistic function is the foundation of multiple complex growth models that people use to predict cancer growth, such as Gompertz model. It's based on the logistic growth model. And the bi-exponential model can effectively represent these phases by combining the two exponential functions, each with different constants that might represent, for example, an initial aggressive growth, followed by the subsequent slower growth, or even decrease due to the change in environmental conditions. And after all the background information, it leads to my three research purposes: to analyze the correlation of patient demographics, including age and ethnicity, as well as tumor clinical metrics that include initial cross-sectional area and net area change on patient survival status. In addition to the correlation, analysis, I also modeled tumor progression with different types of models, the aforementioned models, and then compared the effectiveness of each model. So the data collection portion involves me going to Queens Medical Center to get access to the clinical trial data from Dr. Kova. And thank him so much for providing me with the data. And after getting data, I looked at all the patients and the tumor clinical metrics involving demographics and cross-sectional area change over time. And the total number of the patients is 17, but some people, they had multiple tumor lesions, making the total number of data points 34. And patients received constant dosages of antibodies, TSR-022 and TSR-042, with 1,000 milligrams per 6 weeks. And one CT scan is taken every 9 weeks, starting with one initial scan. And the age range in the clinical trial is from 48 to 86, with everyone being male, coincidentally. And I collected data on, or we collect the data from on patient age, race and ethnicity, gender, survival status, tumor cross-sectional area of each scan, initial size, number of treatment cycles, and lesion descriptions. First of all, let's talk about the demographics analysis and what I found. So by using the pivot tables in Excel, I analyzed the correlation between patient demographics and their survival status. I then created graphs to visually determine if there's any correlation or linkage between the demographics and survival status. And looking at the survival status versus age graph, the range is, again, from 48 to 86, and there are 17 patients with 34 tumor points in total. There is a subtle trend, as expected. General survival decreases as age increases, as there is gradually more red, as you see when it moves to the right. And this makes sense because of the weakened immune system and reduced responsiveness to the antibodies used in clinical trial. In the data set, there are 7 races and ethnicities amongst the 17 patients and 34 data points, with Native Hawaiians being the most common race. Unfortunately, the takeaway of this chart is that we cannot determine the correlation between ethnicities and survival status due to the small sample size of the clinical trial that I was working with. But after playing around with the graphs, it showed no obvious results as the outcomes are really extreme. For example, African Indians on the left, they had 100% survival rate, but Caucasians on the right, they had a 100% fatality rate, which is not realistic. Now moving on to tumor clinical metrics analysis. The methodology is similar to that of demographics analysis, which involves making pivot tables and graphs to determine the correlation between tumor cross-sectional area and patient survival status. And looking at the survival status versus cross-sectional area from the initial scan, with the size ranging from 5 millimeters squared all the way to 167 millimeters squared, individuals who survived concentrated more at the middle of the graph. As you can see, there's more blue at the middle of the graph, which indicates that survival peaks when the initial tumor size is close to the median cross-sectional area of 25 millimeters squared. And the change in tumor size versus survival status is also interesting. And everyone who is alive showed, or like everyone who's alive on the right, it showed a net decrease in tumor size, while everyone who died on the left, it had a more positive tumor cross-sectional area change. So every point on so the data points on the right for everyone who is alive had like a negative change in tumor cross-sectional area, whereas on the left, everyone who died has a more of a fluctuation in terms of change in tumor cross-sectional area. And it had both positive and negative changes. Now, after looking at the correlations of various factors, it brings us to the second part of the research, modeling tumor progression dynamics. With the help of Dr. Lemusio, I was able to use Python to perform all the model and parameter fitting for all of my desired models, which includes, once again, linear, logistic decay, as well as by exponential decay models. And after fitting the models to each tumor, I computed the AIC values of each individual fit. And then compared the average of AIC values to determine the best fitting model for the data point. AIC, or the Akiki Information Criterion, is a way to measure how a model fits the data while taking into account the complexity of the model. In other words, AIC allows us to compare multiple models that use varying numbers of parameters by penalizing their complexity, which avoids overfitting to ensure a better performance on new unseen data. And on the AIC equation right here, it's like how you calculate the AIC value, and N is the number of data points, RSS is the residual sum of squares, and K is the number of parameters in the model. Then we used R to run the linear regression model analysis to see how each factor or parameter affects the net area change by testing for the statistical significance. Then ideally, the model is fused with the statistically significant factors to predict tumor progression of new data, but I was not able to accomplish the last step as of this point. First of all, the linear model is used first as a starting point, as it's simple to fit, and then it's easy to understand. It's pretty efficient. It's a great baseline model to pave the way for more complex models. And I fitted this model 34 times for all 34 tumors or data points. And this figure is an example calculation of tumor 1A, or model fitting for 1A. And then tumor growth dynamics is nonlinear, so it consequently yielded a really high AIC value. After that, the logistic decay model was fitted the same way as the linear model, but with more parameters. And I fitted this model 34 times in total for all 34 data points once again. But it only showed the process for tumor 4B as an example. And since the model only has one growth factor, it does not take into account the multi-phase growth dynamics. But the behavior is still non-linear, so it should be a better fit than the linear model. And lastly, but certainly not the least, I used the bi-exponential decay model to fit the data. And just like the previous two models, it returned all the individual optimal parameters and AIC values. And unlike the other models, the bi-exponential decay model accounts for two distinct growth factors, which enables a more nuanced understanding of different phases or components of the progression process. This approach is advantageous when it comes to because like when the data is exhibiting phases with varying rates of growth and decay. So it provides a more accurate and comprehensive fit. And there are 34 tumors in total, but this is only showing one of the tumors, tumor 10B, for example, for the example model comparison. We're able to compare the three models by looking at the average AIC values. So we can do that because only the trials where all three of the models are fitted are included in the average calculations. Since a more negative AIC value indicates a better fit, the bi-exponential decay model is the best fitting model here, followed by the logistic decay model, then the linear model. Also, take a look at the progression pattern it's like the scatter plot. And considering how the immune system works, the initial enlargement of the tumor size is likely due to the inflammatory response that provides protective immunity upon the initial injection or interaction with the antibodies. And this is a part of a normal host defense system in which the goal is to eliminate pathogens. And this specific response could be inferred as the therapy-induced inflammation, which is really normal. And the decrease in tumor size as seen in the preceding scans indicates the effectiveness of the antibodies or the treatment modality. And from this, we could utilize mathematical modeling and parameter fitting to determine and predict the growth of the tumors, which then can be used in actual clinical trials for personalized prediction of how the model is going to progress, which leads to the next step. Initially, I wanted to look at the statistical significance of patient demographics and tumor clinical metrics and use the results from the linear regression model analysis to help predict the significance of the parameters from the models. And turned out the initial tumor size was the only statistically significant factor that affected the net change in tumor size, as the p-value is less than 0.05. However, there was no clear correlation between the various parameters and the demographic and clinical metrics. But looking at the QQ residuals graph, the nonlinear behavior suggests that the linear regression model analysis might not be the best model or method to test for statistical significance. And finally, moving on to conclusions. We're able to see from our results that there is observed to be a correlation between age and survival status, that survival tends to decrease as age increases. But unfortunately, we were not able to draw any conclusions from the ethnicity versus survival status, as the sample size was way too small for us to deduce anything significant. For most ethnicities, it's either 100% survival rate or 100% fatality rate, which is not realistic. Then, in tumor clinical metrics analysis, we were able to see that for everyone who lived, it showed a net decrease in tumor size, but not everyone who had a decrease in tumor size survived. Also, patients who died had a greater fluctuation in cross-sectional area change from tumors to tumors. And from the survival status versus initial cross-sectional area data, we were able to observe that the greatest survival was concentrated at the median tumor size of 25 millimeters squared. And lastly, for the mathematical modeling part, bi-exponential decay turned out to be the best fitting model of the data set due to the addition of a dual growth model, or dual growth factor. And this was determined by comparing the average AIC values of the three models. Unfortunately, we were not able to determine the significance of each parameter due to the seemingly unrelated correlation between the demographic and clinical metrics factors and the tumor area change. For future research, I would like to focus on performing the same process and experimental analysis on the same types of cancer, or different types of cancer, sorry, with more variables and parameters, so that we can compare and contrast the effect of demographics on cancer dynamics and survival status. And a more interesting to do in the future would be to use more complex models to get a more accurate or even more comprehensive understanding of how tumors grow, while considering the biological factors and other demographics, such as gender. And of course, a more revolutionary thing to do would be to look at, would be able to determine the significance of the optimized parameters so that we can use, that we can incorporate in models in actual clinical trials. And the biggest limitation in my research would be the small sample size. And if I were to use a bigger sample size, my results could be more accurate, and maybe I could draw some kind of conclusion for the correlation between ethnicity and patient survival status. And throughout the research, it was a long journey this year, and I've learned how to ask meaningful questions that are helpful to me, or like my research. And I also realized that things might not really go your way, so you have to adapt and change things up constantly. And I also learned that by allotting your time well is like a really essential skill to have in order for you to keep up with everything. This not only applies to research, but for all the other aspects as well. And for people who are taking honors independent research next year, here are my top three pieces of advice for you guys. First of all, do not hesitate to ask teachers questions. Think about your project as soon as possible and collect data early. As well as do not procrastinate. If you manage these things well, then you'll do just fine. And lastly, I would thank Dr. Lucio for helping me with all the math and coding portions of my research. Certainly, it wasn't an easy job. And thank you, Dr. Okova, for providing me with the cancer data. And it would not have been possible without like the real actual clinical data. And thank you, Dr. Chan, for meeting and checking in with me constantly and helping me push through the hard journey. And thank you, Mr. Hill, for helping me with some Python code and troubleshooting. And also thank you, Ms. Kobayashi, for always like saying hi and like being there with me for the support. I also want to thank Peer 2 Research too for helping me and providing me with entertainment every time we meet. And also a special thank you to Sebastian Ben Sekri for providing us with the free mathematical oncology courses and Python codes and slides to the hard concepts that we encountered through the journey. Here are my references. Thank you all for coming. We're happy to take any questions.